the heart is not pumping well, there will be accumulation of blood in the heart chambers. So there will be high pressure in the cardiac chambers. So that will actually hamper the venous return. How? Because the veins actually drain into the atrium. So if the pressure in the atrium is high, then veins need more force to release the blood in the in heart failure. In fact, the edema, be it dependent edema, generalized body edema, or the pulmonary edema, this edema is the hallmark of heart failure. That is why heart failure is also named as three mechanisms are activated. One is renin, angiotensin, aldosterone system. Another one is posterior pituitary, and another one is sympathetic nervous system. So what do they do? Actually, they are activated for the benefit of the body. So what does it do? Yes, if renin angiotensin system is activated, there will be production of more aldosterones. So aldosterone will cause salt retention that will increase the blood volume. So if blood volume is increased, the cardiac output will also be increased. ADH causes water retention in the kidneys, so it will also increase the blood volume. Consequently, cardiac output will also be increased. Adrenaline and noradrenaline, they actually increase the contractility of the heart. They act and water retention respectively. That leads to increased blood volume restriction by acting on the alpha receptors. And renin angiotensin aldosterone system, apart from ejection fraction is the fraction of the end diastolic volume which is ejected through cardiac output. So when cardiac output is normal, the ejection fraction will also be normal. In this group of patients, the main abnormality is not the reduction of cardiac output, rather an increase in the pressure in the cardiac chambers. And this increase in pressure in the cardiac chambers is called elevated filling pressure. That is why the definition of heart failure is a bit modified, a bit complicated than the basic simple one. And that is, heart failure is a condition when heart cannot pump adequately as per body requirements, or there will be a high or elevated filling pressure in the left heart. So there will be reduced venous return from the pulmonary veins. There will be pulmonary venous congestion that ultimately will lead to pulmonary edema. So there is edema in the lungs, and this pulmonary edema will hamper the oxygenation of blood. That is why the main symptom of left heart failure is dyspnea, shortness of breath, respiratory difficulty. There are three typical characteristics of the shortness of breath in left ventricular failure. One is exertional dyspnea. This actually happens when the heart failure is new onset. In the initial days, in the early days, the dyspnea does not occur when the patient is at rest. It occurs only when the patient does some physical exertion. That is why it is called exertional dyspnea. But remember, it occurs only in the early days. Later, when the heart failure is more severe, the dyspnea persists all the day long, but still they are aggravated when the patient tries some exertional activities. That is why it is called exertional dyspnea. That is that you are less likely to pass if you fail to answer this. This is a very important question in the MBBS final prop exam. What are the three cardinal signs of left ventricular failure? One is pulsus alternans, one is gallop rhythm, and one is bilateral basal crepitations. So what is pulsus alternans? It means there is alternating strong and weak pulses. One pulse will be strong, the next pulse will be weak, the next pulse will be strong. So there is alternating strong pulse and weak pulse. This is pulsus alternans. The gallop rhythm means uh, presence of the third heart sound. In normal conditions, only first and second heart sounds are audible, just as lub dub, lub dub, lub dub. But in gallop rhythm, there will be three heart sounds. The third heart sound will also be audible, and it bit sounds a bit like the sound of the running horse. Nasal crepitation means that the crepitations are audible more from the back of the lungs, from the back of the chest. The lung, because of the oblique fissure, the anterior part of the lung is actually the upper lobes, and the posterior aspect actually represent the lower lobes or the base. So that is why as pulmonary edema uh, normally accumulates in the more dependent part of the lung, so the crepitations will be more prominent in the lower part or the bases of the lungs, and bases are audible more from the posterior side. That is why bilateral basal heart failure is myocardial infarction. And then another very important and very common cause is hypertension. And number 3 is mitral or aortic valvular disease. So these 3 are the common causes. Even if you mention only these 3 in the prof in the exams, that's fair enough. Yes, the other hypertension and aortic or mitral valvular disease, the mirror image of the left heart failure, but only the structures are different. Structures affected, the circulations are different. What happens? Because of the accumulation of blood in the right side of the heart, there will be elevated filling pressure in the right heart. So the systemic veins will find it difficult to release the blood in the right heart. So there will be systemic venous hypertension, and finally there will be systemic edema. The edema which is more prominent in the dependent part is called dependent edema. And they are also present in different organs of the body. Even the that is generalized edema, which is most prominent in the dependent parts. And then the most important question from right heart failure, that is the 3 cardinal signs of right heart failure. These are raised jugular venous pressure, tender hepatomegaly, and dependent edema. Jugular venous pressure rises naturally because the jugular veins cannot release the pressure, cannot release the blood into the right atrium because of the elevated filling pressure in the right side of the heart. So there will be accumulation secondary to left heart failure. Usually, most of the causes of left heart failure they lead to pulmonary hypertension. That is a rise in the pressure of the pulmonary arteries, and that lead so there is a increased resistance of the right heart to pump. So there will be right heart failure. And another condition which is called cor pulmonale. So what is cor pulmonale? Cor pulmonale means right ventricular hypertrophy due to pulmonary hypertension, which is due to primary disease of the respiratory system. So there is a disease of the respiratory system that leads to pulmonary hypertension, and that leads to right ventricular hypertrophy. It's the same mechanism, increased workload, okay, increased resistance, I'm sorry. So what are the conditions commonly cause cor pulmonale? One is COPD, that is the majority, more than 90% of the right ventricular failure are secondary to COPD. Then interstitial lung diseases, and another condition where the pulmonary arterial pressure is persistently high uh, due to no cause. No cause is found ventricles, thyrotoxicosis, cardiomyopathy, and myocarditis. In heart failure, there is usually reduction in cardiac output. Thereafter, I mentioned in some cases there will be no reduction, there will be normal cardiac output, and we termed it uh, heart failure with preserved ejection fraction. But now there is a condition when the cardiac output is more than normal. This is called high output failure. And this high output failure actually is not a problem in the heart itself. It occurs due to increased demand of the body. Okay. So because of the increased demand of the different tissues of the body, heart pumps more than patients presents with shortness of breath. So other common conditions which also present with shortness of breath should come as the differential diagnosis of heart failure. So I have put this differential diagnosis according to the age of the patients, because I think these differentials may help you to make the differential diagnosis if you get a heart failure case in your long case. If the patient is less than 50 years age, that is, we call them young patients. Although 50 years, 48 years, 47 years, they are not much young, but still we term it young patients, that is, who are less than 50 years age. The main differentials will be bronchial asthma and psychogenic dyspnea. And those who are 50 or more, the differentials will be chronic obstructive pulmonary disease, COPD, bronchial asthma, and interstitial lung disease. So let's talk, how can you distinguish these conditions from heart failure uh, at bedside without doing any investigations. First of all, let's talk about the differentials in the EM. So if you get a case of heart failure, then you have to distinguish it from bronchial asthma. So if you are asked why this is heart failure, you just have to tell that this is heart failure because the patient is dyspneic and there are bilateral basal crepitations. This is good enough evidence to call it heart failure. And then if you are asked, then you why this is not bronchial asthma? So if you are asked such a question, you have to tell that this is not bronchial asthma because there is no diurnal or seasonal variation of symptoms. Because in asthma patients, the dyspnea increases at night. In fact, the dyspnea increases in particular seasons, particularly in the winter seasons. So in heart failure patients, there is no such variation. Number two, there is no vesicular breath sound with prolonged expiration, and there is no rhonchon. In asthma, we expect the breath sound to be vesicular with prolonged expiration, and in psychogenic dyspnea, actually the breathing pattern is bizarre. And if you examine the chest, there should be no abnormal finding. Shell will be COPD. So why this is heart failure and why this is not COPD? If you are asked, then you have to say that this is not COPD because there is no vesicular breath sound with prolonged expiration and there is no rhonchon, just like bronchial asthma. Please don't start with the term there is no history of smoking, because smoking, yes, smoking is the most common predisposing factor behind COPD, but absence of smoking, although it virtually excludes COPD, but the presence of smoking does not exclude other disorders. Suppose a patient is asthmatic and he or she is a smoker. So you cannot tell, as because he is a smoker, this cannot be asthma, this is COPD. As because he is a smoker, this cannot be heart failure, this is COPD. So smoking is important in the diagnosis of COPD, but no childhood onset. There is no diurnal or seasonal variation of symptoms. And again, there is no chest findings like vesicular breath sound, which mimics heart failure more closely. Why? Because these patients also present with dyspnea, and you will also have bilateral crepitations in these patients. So they are actually very difficult to differentiate from heart failure. But one point that clearly indicates heart failure is orthopnea. In heart failure, the dyspnea will increase when the patient lies down, but in interstitial lung disease, the dyspnea is not affected by the posture of the patient. So this is not interstitial lung disease, rather this is heart failure because there is orthopnea and there is no suggestive occupational history, because very common cause of interstitial lung disease is occupational lung diseases like pneumoconiosis, poll workers, pneumoconiosis, asbestosis, silicosis. So there will be some occupational history of exposure to these things. And another one important cause is idiopathic pulmonary fibrosis, where you expect a clubbing. So as there is no suggestive occupational history and there is no clubbations or respiratory failure because of the pulmonary edema, it hampers the oxygenation. Then the cardiogenic shock, when the cardiac output is very low, there is the overall reduced tissue hypoperfusion leading to cardiogenic shock and cardiac arrhythmias. Acute kidney injury occurs and also electrolyte imbalance. So why this complication occurs? I tried to cardiogenic shock occurs due to reduction of cardiac output. Acute kidney injury, this is a result of reduced renal perfusion. So this is a kind of pre-renal failure. And arrhythmias, this is multifactorial. There are different factors that can cause arrhythmia in a heart. One is sympathetic activation, then cardiac remodeling. It means ventricular enlargement or ventricular hypertrophy that occurs due to increased filling pressure. And also there is electrolyte imbalance like potassium hyperkalemia or hypokalemia that also makes the heart prone to arrhythmias. What are the arrhythmias in heart failure? The common arrhythmias are atrial fibrillation, ventricular tachycardia, and ventricular fibrillation. Hyperkalemia and hyponatremia, all these three can occur. Hypokalemia usually occurs due to activation of the renin-angiotensin-aldosterone system. That causes formation of aldosterone, which causes retention of sodium and removal of BNP. ECG is the first investigation to be done, as ECG is the most important investigation of any cardiac disorders. So it is done in heart failure. It must be done in heart failure. But the truth is, ECG is never diagnostic of heart failure. ECG cannot diagnose heart failure. But it has its own importance in the investigation of heart failure. Why? Because it can identify causes like myocardial infarction, and also it can detect arrhythmias. Arrhythmias are common complications of heart failure, already mentioned. So to detect the cause and to detect arrhythmias, we have to do ECG. The next investigation is X-ray chest. And in X-ray chest, there are certain findings that are suggestive of heart failure, just like enlargement of the cardiac shadow. Then upper lobe diversion of veins. It means normally the veins are more in number and size in the lower part of the lungs. But if the veins in the upper part of the lungs becomes equal or more in number or in size than the lower part veins, then it is called upper lobe diversion of veins. Then there are Cardiac lines. These are small, very small horizontal lines in the periphery of the lung fields. So I hope the connection is regained. This is upper lobe diversion of veins. The upper lobe veins are prominent. This is actually a schematic diagram. This is not actual X-ray, and this is enlargement of the cardiac shadow. These are diffuse opacities. These actually occurs due to pulmonary edema, and finally there are pleural effusions. So this is the ideal. Actually, it looks like this. So there is enlargement of the cardiac shadow, and diffuse opacities in both sides. And these diffuse opacities are more prominent in the central region of the lung fields. So this is the practical X-ray of heart failure, and this is the ideal X-ray of heart failure. Practically, you will not get these findings. Commonly finding from the parameter that determines whether this is heart failure or not is the ejection fraction. It should be more than 50% or equal to 50% in normal person. If it is less than 50%, we call it heart failure. Echocardiogram is not important only for the definition or the diagnosis of heart failure, but also it helps in detection of the causes like ischemic heart disease, valvular heart disease, or cardiomyopathy. It is a biomarker of heart failure. It raises in all forms of heart failure. So it is useful in those people who have heart failure, but still the ejection fraction is more than 50%. I have already said that there will be a group of people having we call heart failure with preserved ejection fraction. So if you find such a patient, you suspect clinically this is definitely heart failure. You do the echocardiogram, but unfortunately you found ejection fraction 50% or more. So still you can call it heart failure if you find serum BNP raised in these patients. So serum BNP is extremely helpful in diagnosis of heart failure with preserved ejection fraction when echocardiogram is not showing a low ejection fraction. Okay, now about anything that reduces the workload of the diseased heart, contraction, be it preload, be it afterload. So there are different inhibitors, angiotensin receptor blockers, loop diuretics, even beta blockers, aldosterone antagonists, nitrates, and cardiac glycosides used myocardial contractility. So they reduce the myocardial contraction and reduce the cardiac workload. The two beta blockers that are frequently used for heart failure are carvedilol and bisoprolol. They and decrease the cardiac workload.